Good afternoon, everyone. Today, in this session of Cuddles Online Neonatal Education, we will be discussing about the diagnosis of neonatal sepsis and the role of various biomarkers in diagnosing sepsis and artificial intelligence and its importance in the new era of diagnosing neonatal sepsis. So, let us go through some case scenarios. So, whenever we are attending the delivery of a baby or subsequently in NICU, we are always faced with the dilemma of diagnosing the sepsis in the baby based on the various symptoms and the risk factors. So, if a baby is born at 34 weeks of gestation to a G2P1L1 mother by spontaneous vaginal delivery, uh, where the mother had an episode of temperature just before the delivery during labor, and she also had premature rupture of membranes. So this baby cried immediately after birth, subsequently was started on continuous positive airway pressure. X-ray chest was suggestive of respiratory distress syndrome. So would you start antibiotic in this baby? If we are faced with this scenario, then we should look at certain guidelines and decide about the beginning of antibiotics in the baby. So these are the guidelines given by NNF CPG, in which there are the risk factors are given as red flag and yellow flag signs. So among the red flag signs, any clinical signs of chorioamnionitis in the mother, either the temperature being more than or equal to 39 degrees centigrade one episode, or 38 to 38.0 to 38.9 degrees centigrade on two or more measurements 30 minutes apart, plus one or more of the following. That is A, baseline fetal heart rate more than 160 beats per minute for more than 10 minutes, maternal white cell count more than 15,000 per mmq, and purulent appearing fluid coming from the cervical os when examined by visual speculum examination. Either this sign or any foul smelling liquor is taken as a red flag sign in the mother. Coming to the yellow flag signs, any premature rupture of membranes or prolonged rupture of membranes more than 18 hours, or any intrapartum fever in the mother more than 38 degrees centigrade in the presence of suspected or confirmed bacterial infection, and any unclean vaginal examination or delivery in an unclean setup is considered as an yellow flag. So now, based on the gestation of the baby, we consider for babies who are asymptomatic and born less than 35 weeks with the above maternal perinatal risk factors for early onset sepsis, if the baby is more than 35 weeks, we should start antibiotics only if CRP or procalcitonin are elevated or any other lab abnormalities are noted. Not for the baby who is just started on CPAP for respiratory distress syndrome. If the baby is between 32 to 35 weeks of gestation, then we should look at the above red flag, one red flag or two yellow flag signs, and then decide about initiation of antibiotic. For a baby who is born at less than 32 weeks, any red or yellow flag is considered to as a indicator to begin the antibiotic. So these are the guidelines for the initiation of antibiotic in any baby where neonatal early onset sepsis is suspected. So now let us move on to the question 2. When will you consider doing lumbar puncture in this baby? So in early onset sepsis, in case of a positive blood culture in an asymptomatic baby with maternal risk factor, or if the neonate is symptomatic with signs of sepsis, we should do lumbar puncture and CSF analysis to rule out meningitis. And in all cases of late onset sepsis, we should do the lumbar puncture to do the to rule out the meningitis. So coming to the question number 3, a 25 weeks baby who was born from a mother who was steroid covered by LSES. Subsequently, the baby was ventilated due to poor respiratory efforts. On day 1 of life, baby was started on first line of antibiotic in view of preterm delivery and premature rupture of membranes. The baby was initiated on total parenteral nutrition. So the baby was extubated to non-invasive mechanical ventilation on day 3. On day 6, the baby was noted to have increased heart rate, respiratory rate, and a screen echo was done which shows PDA. The baby also starts developing some feed intolerance in the form of residual gastric aspirates and increased abdominal distension. So these are also some of the signs which are suggestive of sepsis in this baby. In this scenario, it can be a late onset sepsis. And the sugar levels also became high, being 201 milligram per deciliter. Serial CBC monitoring was done in this baby, which showed a drop in the WBC count and also a significant drop in the platelet count from 4.3 to 1.8 lakhs. So if we have to categorize, there is as such, there is no clear-cut definition of the neonatal sepsis where the role of these biomarkers take very much importance in the decision about initiating the antibiotics for the babies. So when we are defining the types of sepsis, so we can broadly categorize the neonatal sepsis into 3 categories. Those are definite or culture positive sepsis, where the culture comes positive and we can identify the organism which causes the sepsis and also the sensitivity of the same. The second one is probable sepsis, where the biomarkers of the baby become positive, but the blood culture remains negative in a baby with a background of the signs of neonatal sepsis. Possible sepsis is where both the lab parameters and the blood culture are negative, but the baby is having some signs which are attributed to the neonatal sepsis. So in the above scenario of 25-weeker baby, what are the risk factors? The baby being extreme premature and being on mechanical ventilation, having central lines and being exposed to parenteral nutrition, these are all the risk factors for the baby to have a onset of hospital-acquired infection or late onset sepsis. So the clinical and laboratory features that we noted in this baby are worsening of respiratory distress, having feed intolerance, having abdominal distension, tachycardia, reopening of PDA, need for inotropes, need for resuscitation, etc. So in this scenario, we also noted that the baby had a decrease in the WBC and the platelet count. What are the subsequent steps for this baby? So in this baby, we should send the blood culture immediately when you are suspecting the late onset sepsis. Send the blood culture and start empirical antibiotics. So coming to defining the neonatal sepsis, so in various randomized control trials, the different symptoms of the baby are noted. So there is no such clear-cut one definition for neonatal sepsis, but based on the different system involvement, we can identify the sepsis in the babies. So the constitutional symptoms being baby having lethargy, temperature instability, feed or glucose intolerance, hypo or hypothermia, irritability, poor feeding, excessive cry. Respiratory symptoms being increase in the respiratory rate or apnea, and worsening of the retractions, desaturations, and need for ventilatory support. Among the cardiovascular signs, baby having hemodynamic instability, mottling, poor perfusion, poor pulses, core peripheral temperature difference, CRT being more than 3 seconds, need for inotropic support can be considered among the cardiovascular factors. In the neurological factors, altered consciousness, seizures, hypotonia, bulging fontanelle, and reduced reflexes are taken. Among the GI-related factors, abdominal distension, vomiting, hepatosplenomegaly, jaundice, and increased residual gastric aspirates are seen. Other miscellaneous factors are petechiae and purpura. Sclerema is seen in severe sepsis in the babies. So any baby can present with one or multiple of the above factors, which may be non-specific for the sepsis, which can also be seen in other sepsis-like conditions also. The corresponding lab parameters being CRP, WBC count, IT ratio, neutrophil count, platelet count, micro ESR, band cell count, full blood count, IL-6, glucose, and toxic granules in the peripheral smear. And other variables being lactate, pH also are taken into account in the regular day-to-day decision making of initiation of antibiotics for the neonatal sepsis. So as we discussed, the next step in this baby is to send a repeat blood culture and start the baby on empirical antibiotics. So now, so why we need to talk about the biomarkers in the baby? So as the neonatal sepsis signs are very non-specific, we are initiating the baby on the empirical antibiotics. So there is more and more a need for for having a unique biomarkers which help in early identification of the neonatal sepsis and also help in choosing the antibiotics for the same, and also to cut down the unnecessary antibiotic usage in such babies, to decrease the prolonged antibiotic exposure and the subsequent complications of the same. So in this scenario, there is a need for a ideal biomarker which can help in identifying the neonatal sepsis before the onset of the proper clinical signs, which may also cause a delay in the antibiotic initiation and thereby also can lead to increase in the mortality in some babies. So now let us discuss about these biomarkers one by one. An ideal biomarker should always help us in initiating early antibiotic use, and it should help in early diagnosis, and it should also help in antimicrobial stewardship, that is, avoid indiscriminate use of the antibiotics. The sensitivity of such a biomarker and negative predictive value should be near 100%, whereas the specificity and positive predictive value should be more than 85%. So this biomarker should rapidly increase after the disease onset and equally rapidly decrease after treatment. Reliable info should be there to start and stop the antibiotic, and the biomarker test should be the one which is easy to perform with a fast turnaround time and should be able to have the well-defined cutoff levels and should be easily comparable between different NICU setups and cost-effective. And it should not be affected by the maternal, perinatal, and postnatal factors. Such an ideal biomarker is still not available, but we can use combined different biomarkers, and in combination of two or biomarkers, we can rule out sepsis and also decide about the duration of antibiotic usage. So let us have a brief overview of this statistics of positive predictive value, sensitivity, and specificity, and negative predictive value. In this, we will take a test which is gold standard, in this being blood culture. So if blood culture is positive, we can take it as a true positive in a baby. The parameter which we are testing, if it is also positive, then it can be taken as a true positive. So in this example, I have given it as true positives being 5. False positive is when the test in question has come positive, but the blood culture in this case is negative. So that is false positive. When actually there is not an infection, the test is showing it as a positive. So that is false positive. So the total of this cumulative A plus B will come in this case to be 10. So that is the A by A plus B will be the positive predictive value of such a test. In this case, it is around 50%. So negative means when the test is negative, but the blood culture is positive. So that is false negative. And the true negative is the test is also negative and also the blood culture is negative. So in this baby, so if the negative predictive value, if we take D by C plus T, so that will come to around 100%. That means the negative predictive value of this parameter is 100% for the parameter which we are testing. Sensitivity, on the other hand, we test by true positive by true positive plus false negative. So that is in this case, it comes to around 100%. Specificity, we take it as true negative by true negative plus false positive. In this scenario, it is 94.7%. So now the first biomarker which we commonly use in all setups is the blood culture. Blood culture is the gold standard in defining the neonatal sepsis. But in many scenarios, either the volume of the sample connected or the inoculum might be less due to various reasons like lack of knowledge about the volume and also lack of the blood volume which is collected in that particular prick from the baby. So then also the blood cultures can come false negative. And we should also avoid the sample blood culture drawing from indwelling lines. And the drawback of the blood culture is it has a long turnaround time and it also has a low sensitivity and is an invasive procedure. So there are different types of blood culture systems. So the common ones being the BACT alert, BACTEC, and VersaTrek. So BACT alert, how do they means alert us about the growth of the microorganism? There will be a color change caused by a drop in the pH from increased CO2 levels due to the metabolism of the bacteria in the medium. So these volumes are given for adults actually. For neonates, 1 ml of the volume is enough. Backtech similarly also causes change in the fluorescence caused by a drop in the pH from increased CO2 levels. Versatrek is another method of blood culture system in which the pressure changes are measured by gas consumption or production. So these are the automated blood culture systems where they give the uh, values or results a little earlier than the conventional blood culture systems. So after identifying the organism, we have to do a subculture, gram stain identification, and antimicrobial sensitivity testing. So this is the backed alert system. So in which the around simultaneously 120 to 240 blood culture bottles can be kept, and it contains an incubator, shaker, and detection device. So this is the first non-radiometric continuous blood culture monitoring system. So this can be used for culturing the various body fluids such as blood or any sterile fluid or respiratory and non-respiratory samples. And it can detect both aerobic and anaerobic blood culture samples. So there are further different other methods of molecular testing. These are commercial FDA cleared molecular tests which are identified available for rapid identification less than 2 hours of organisms in positive blood culture bottles. So these tests target either a single organism. For example, if we are having a single organism repeatedly in our NICUs, which is the culprit for the many babies with neonatal sepsis, we can test for that single organism, or a large panel of organisms also can be tested simultaneously. So that is gram negative and gram positive bacteria on the same test, or organized by the gram stain results. So for these molecular based methods, that is the polymerase chain reaction test, the sensitivity and specificity are relatively high, around 96%. They help in earlier and quick diagnosis of bacteria from the blood sample. So there is another assay called as Biofire Film Array Panel, that is the BCID panel, in which the different bacterial targets are identified on a quick basis compared to the conventional blood culture methods. So you can see here there are a panel of bacteria which are listed, which cause the common neonatal sepsis in the babies, and the other antimicrobial gene resistance can also be detected from the BCID panel. The turnaround time for this is relatively lower, around 1 hour. So there is a newer method called as MALDI-TOF, in which it is, the full form is the matrix assisted laser deabsorption or ionization time of flight method, in which we identify by a mass spectrometric profile of protein and largely RNA proteins of the organism. If we are able to identify a gram-positive organism in the backtech method of the blood culture, to identify the type of organism based on the protein or RNA protein of the organism, we can use this MALDI-TOF method, which utilizes by the method of the spectrometry, in which the chemical compounds are ionized into charged molecules and the ratio of their mass to charge is measured. So that is the mechanism of action of this MALDI-TOF. There are two systems which are commercially available, VTEC system and Biotyper system. So I thank Dr. Vani, our microbiologist, for these few slides on the different types of blood culture methods. So now let us move on to the our routine sepsis screen. The sepsis screen is relatively easier to perform and it is available in every NICU setup, and the turnaround time is relatively fast. But the drawback of this sepsis screen is the various parameters are affected by the maternal and perinatal conditions, such as the maternal hypertension, mode of delivery. So the CRP and the various biomarkers like PCT are affected by the mode of delivery, such as it is slightly higher in spontaneous vaginal delivery and emergency LSCS compared to elective cesarean deliveries. And also, if the mother is administered any intrapartum antibiotics, these values can come falsely low. And these are also affected by the gestational age and hours of the baby. The components of sepsis screen, as we all know, are total leukocyte count. In this, the leukopenia in neonates is being more significant, and absolute neutrophilic count. This is available with various charts like Monro and Mozzino charts. And immature to total neutrophil ratio, any value more than 0.2 is considered as significant. Micro ESR more than 15 mm in the first 1 hour, CRP more than 1 milligram per liter. So any two positive markers can be taken to start an antibiotic in a baby with signs of sepsis, or in case of early onset sepsis, those maternal risk factors, yellow flag and red flag risk factors, can be taken into account if there are positive lab parameters also to initiate the antibiotic. So if two markers are taken into consideration, the sensitivity increases to 93 to 100%, the specificity to 83%. Positive predictive value is low for these tests, and negative predictive value is very good. So that means the normal CRP or PCT negative sepsis screen helps more to rule out the sepsis than to rule in the sepsis. So now let us see one of these biomarkers one by one. CRP. What is C-reactive protein? C-reactive protein is a pro-inflammatory cytokine. After the any like bacterial infection or inflammatory trigger, the pro-inflammatory cytokines like IL-1, IL-6 and TNF-alpha stimulate the production of CRP, which goes and acts on the phosphocholine on the bacterial membrane, and thereby it stimulates the further complement cascade and phagocytosis. So that is the role of the CRP, which we do in everyday practice. So the CRP begins to rise 10 to 12 hours after the infection and peaks at 48 hours. You can see this. So this is not helpful for the baby. If the baby starts to have infection at one point of time, if we see the peak CRP after 48 hours, it is not going to help us in about the decision to initiate the antibiotic. And also the half-life of CRP being 18 to 20 hours, it goes down slowly after the initiation of antibiotic and controlling the infection. So the sensitivity of CRP is around 62% and the specificity is around 74%. CRP is not only a marker of infection, as we all know, it is also an inflammatory marker which rises following prolonged labor, prolonged rupture of membranes, meconium aspiration syndrome, delayed transition after birth, hemolysis, IVH, and perinatal asphyxias, which out of which many are non-infective causes. So a single value of CRP cannot be taken to initiate the antibiotic therapy. The next one, which is recently practiced more often, is the procalcitonin. So this is being tested recently very much in the neonates in NICU. This is also an acute phase protein which is produced by monocytes and hepatocytes. So the stimulus for production of procalcitonin being the IL-1 beta, IL-6 and TNF-alpha and bacterial lipopolysaccharides directly. Procalcitonin rises relatively fast after onset of infection, that is 2 to 4 hours, plateaus in 6 to 8 hours and returns to normal in 24 hours. So this method of action of procalcitonin is relatively faster compared to CRP. Thereby, the sensitivity of procalcitonin is slightly higher than the CRP, while the specificity is 54%. So, the procalcitonin is downregulated by IFN gamma, which is produced in viral infections. Thereby, procalcitonin becomes even more specific for bacterial infections when compared to CRP in this scenario. So, whenever we are in a doubt of any bacterial bacterial infection or viral infection, to confirm the bacterial infection, we can send the procalcitonin and see, because procalcitonin compared to CRP is slightly more expensive. According to our NNF CPG guidelines, there is no advantage in using procalcitonin routinely over CRP as a screening test for late onset neonatal sepsis. So this also we should keep in mind. Coming to various other factors which were tested in the diagnosis of neonatal sepsis, we can see serum amyloid A, which is produced by liver macrophages and adipocytes, and it also produced in response to the same stimuli as CRP. It also rises faster with a higher sensitivity and specificity, the pitfalls being similar to the CRP. The other one is proadrenomedulin, which is produced by heart, adrenal medulla and vascular endothelium. Stimulus being physiological stress, it regulates the vascular tone and organ perfusion. That is the role of proadrenomedulin. Sensitivity of this is also high, but it has different cutoffs for preterm and term, making it cumbersome to remember all those values. And the various cytokines are also tested for as a biomarkers for identification of neonatal sepsis. These are produced by macrophages and monocytes. Interleukin 6 has the advantage that it rises immediately after a stimulus within 2 hours, peaks by 6 hours, and declines in 24 hours. And its sensitivity is very good in cord blood, which makes it advantageous for early identification in early onset sepsis. There is another new molecule called presepsin, which is produced by monocytes and neutrophils. It also rises in response to bacterial infection, peaks at 3 hours, but it is also dependent on the gestational age, birth weight, type of delivery, and maternal infections. So when we compare the CRP, highly sensitive HS-CRP and IL-6, we see that IL-6 is more sensitive in diagnosing the early onset sepsis. Here you can see the sensitivity of IL-6 being 100%. And the HS-CRP has high sensitivity, but it is very less specificity when compared to the CRP. So based on these factors, we can conclude that HS-CRP is less reliable when compared to CRP as an early marker of neonatal sepsis. So other different adipokines like viscofin, resistin, hepcidin, progranulin, stromal cell-derived factors, endocarn, and pentraxin are all being studied as biomarkers to see if there is any ideal biomarker which helps in early diagnosis of neonatal sepsis before the deterioration of the baby, thereby decreasing the mortality, are being studied. But these need further more studies before they can be routinely used and they brought into the regular practice. So there is another factor called tumor necrosis alpha, which stimulates the production of IL-6. This is also being studied as a biomarker. There are different cell adhesion molecules. The first one is presepsin, which we discussed, and soluble triggering receptor and cluster differentiation molecule. So these molecules, they are like, the presepsin is like a soluble fragment of CD14, that is a cell surface glycoprotein. So whenever their CD14 comes in contact with the bacterial lipopolysaccharide, this complex undergoes internalization into the cell. So then the CD14 is proteolized inside the cell by cathepsin D, and then the presepsin gets released into the circulation. So that is how the identification of the presepsin for early diagnosis of neonatal sepsis is being studied. So these are the different cell adhesion molecules which are being studied for the early identification of the neonatal sepsis. So till now we have seen the biomarkers, that is the blood culture, and in that the different types of the blood culture, and along with the BCID panel, MALDI-TOF, and different newer advances in the earlier identification of the kind of organism causing the infection, and different biomarkers like CRP, HS-CRP, and various cytokines, in IL-6, and different biomarkers which help in the diagnosis of neonatal sepsis. There are also like some studies, like molecular biology studies, in which the genes which participate in the cytokine secretion and inflammatory cascade reaction are also being studied to help in the earlier diagnosis of neonatal sepsis. Like there have been 554 genes which are mainly linked with cytokine expression, which could discriminate VLBW neonates having sepsis from controls. So there are some studies like this one in Pediatrics, published in 2014, where the genome-wide expression profiles in very low birth weight infants with neonatal sepsis were studied, and microRNAs are also being studied. So for the earlier diagnosis of the neonatal sepsis. Next, coming to the microbiome monitoring, what else we can do to identify the organisms, like how else can we predict whether this neonate is going to be all right, or if the neonate is going to go into sepsis or NEC. So is the baby having such risk? So this can be also studied by the volatile organic compound analysis, in which the modifications of the cellular metabolism and gut microbiota composition is being studied. So in these studies, they take the swabs from the oral mucosa, buccal mucosa, and also the skin of the baby, and also the stool samples of the baby, and analyze them on everyday basis to see whether there is any change in the gut microbiota or organic compound profile, that can help in earlier detection of these premature infants who might likely end up with sepsis. So there are different studies which was done on the same principle. So here we can see that in this study of longitudinal fetal microbiota and volatile metabolomics preceding NEC in preterm infants, the levels of Clostridium perfringens and proteobacteria surge, means increase, days before the baby goes into NEC, thereby helping in identification of the baby who is prone to get NEC than the baby who is tolerating the feeds well and having good gut microbiota and unlikely to go into NEC. So now let us see another case. This is a baby who is a 4-week-old now. It is an 28-weeker. This baby is on HFNC and on full OG feeds. So the doctor on duty noticed that the baby had one episode of apnea requiring stimulation. So then only caffeine loading dose was given and the baby was continued on the feeds. There was no further evaluation done for the baby. So after 6 hours, the baby develops abdominal distension, which is significant, around 2 centimeters, and then 2 feeds were skipped for the baby. So subsequently, 4 hours later, so the baby develops respiratory worsening, goes into repeated apneas. The baby gets intubated by the time it was morning, and the baby develops subsequently lethargy, poor perfusion. At that point of time, antibiotics were started, and also inotropes were started. So this baby, at this point of time, at the beginning of the first episode of apnea itself, the baby started having infection. Means the baby could have had the abnormal microbiota in the gut even before this episode, which could have been identified by this molecular biology and microbiome testing. So in this scenario only, these biomarkers can help in earlier diagnosis of the sepsis, thereby preventing the late initiation of the antibiotic and increasing the mortality in such babies. So this baby succumbs to Klebsiella sepsis after 2 days because the antibiotic initiation was done after a few hours after which the baby started having clinical deterioration, because the earlier signs of infection can be non-specific and this can be overlooked because of various other factors which mimic sepsis in such preterm babies. So now comes the role of artificial intelligence and machine learning in the neonatal sepsis. So in this scenario, we have seen like how one doctor who was monitoring the baby, like the early initiation of antibiotic with the help of the human intelligence, which we do every day in our NICU. When we are taking NICU rounds, we decide about initiation of antibiotic, decide about further treatment of the baby based on various factors of the baby, which we will go through in the subsequent slide. Does artificial intelligence help us in any other way in earlier diagnosis of infection and give us any inputs in saving these babies? Yes. So why is artificial intelligence important for neonatal practice? Because the neonates are very much immunocompromised when compared to adults, and they always have lot of invasive devices when they are in NICU, whether it be the endotracheal tube or the peripherally inserted central catheters or umbilical lines. So, or giving total parenteral nutrition, might have feed intolerance. So, various other respiratory support, ventilatory support. So, various other factors might be there for the babies, and they being immunocompromised, they are more at the risk of sepsis. And the neonates, if they start deteriorating, they don't give us much time before we could react and initiate the antibiotics. So that is where the role of artificial intelligence comes into play. And we can also see the outcome for such babies. Like neonates, once properly adequately treated and get discharged, they have the whole life to live on, and they we can see the output in their the improvement in the mortality also when they grow up. So the artificial intelligence is very much important in neonatology, and we should do everything to take the help of such new upcoming modalities, and which can help us in our day-to-day clinical practice. So this artificial intelligence should blend into our everyday clinical practice. It should be easily understandable, and it should help in earlier detection and decision making. Same for the biomarkers which we discussed earlier. We saw that there are many pitfalls or drawbacks for these biomarkers if we see them individually. Collectively, they can help to rule out the sepsis. Blood culture also being less sensitive, like not every baby gets a positive blood culture. Only 30% of the babies who have infection tend to have a positive blood culture. So we need other methods such as AI that can help in the decision making and decrease the mortality and antibiotic overuse in units. So the human intelligence. So this we regularly, like when we are taking around in the NACO, on an average, if there are 15 babies, so one baby might be having feed intolerance, the other maybe might be having the tachypnea, other one might be having tachycardia, other one decreased urine output. So like various scenarios we will see when we are taking the rounds of the babies, and we tend to take decisions based on different parameters of the baby, such as the heart rate, blood pressure, respiratory rate, capillary refill time, pallor, off color, pulse volume, whether the volume is feeble, and the color of the peripheries, if the baby is looking pink or cyanosed or pale, and is there any core to periphery temperature difference? So in sepsis, the core to periphery difference will be more than 3 degrees. Whether the baby is mottled or having hypothermia, needing more temperature support requirement, is the baby going into repeated apnea, and subsequently we should see the overall 24-hour urine output, activity of the baby, sensorium, then the lab values, like is there any increased base excess, trend of lactate, whether it is decreasing or increasing, trend of WBC decreasing, platelets decreasing or not. And we have to take the help of X-rays and echoes and identify the sepsis in these babies. This we are doing successfully, and we are able to save so many babies. But with the support of artificial intelligence, we can save even more and more number of babies. And also, so whenever we are taking a decision to take start antibiotic for any baby, we see, of course, see the trend over the past few hours or last 24 hours. So to see if there is any increase in the heart rate, or decrease in the saturation, or decrease in the blood pressure. Is there any association between the decrease in the blood pressure and decrease in the saturation? So whether the CVP is normal, or the blood baby will be fluid responsive, is there any hypothermia or hypothermia? So all these factors we consider before initiating the antibiotic in a baby. But there is another parameter called as perfusion index, which we should also start looking into whenever we are examining the babies. So the perfusion index is seen in the monitor on the side. If we observe closely, there is another parameter called perfusion index in our multipara monitors, which we should also make a note of. So it represents the amplitude of blood which is flowing through the peripheral blood vessels or capillaries. It indicates the perfusion of the capillaries, and that means whether the peripheral circulation of the baby is good or not. So in other words, any decrease in the perfusion index is an early sign of shock in babies. This is a new parameter which we should all take into consideration whenever we are seeing the vitals of the baby and deciding about the treatment parameters of the baby. This perfusion index is a real-time index. It is non-invasive, and it is reliable and independent variable. In a study which was performed in India by Dr. Deepak Chawla sir and others. So they studied the peripheral perfusion index as a marker of sepsis in preterm units. In this, they have taken a cutoff of perfusion index less than 0.88 as an indication of uh, early sign of shock or sepsis in those babies. So here, if you can see, the value of less than 0.7 on day 1 and less than 1 from day 2 onwards can be taken as a reliable marker of decrease in the perfusion index, which indicates the signs of shock in the baby. So there are different cutoffs which were mentioned. The perfusion index is usually low on the day 1, like 0.7 to 0.9. Then the value slightly increases, and it up to by day 2, day 3 onwards, up to 1.4 is normal for the baby. So then from day 2 onwards, we should take less than 1 as a cutoff for perfusion index in neonatal sepsis. So if we see the sepsis screen positive versus the perfusion index, when the perfusion index is low and the sepsis screen also is positive, so that is the true positive, it is around 62%. So then the positive predictive value is around 73.1 for perfusion index, and the negative predictive value is 24.4%, which is very low. And the sensitivity and the specificity being 89.5%, which is good, and specificity is 56%. So perfusion index is also one variable which should be taken in consideration in neonatal sepsis. Now let us see the scope of artificial intelligence in helping the human intelligence. So the artificial intelligence helps more in monitoring the trends of the vitals over a period of time. So the information we can receive over a long period of time to see where exactly the changes started happening. Some of the examples of these artificial index monitors are the Hero monitor and the Comet scores. And there is something called machine learning in NEC, in which, as I already discussed, everyday samples are collected from the babies who are considered to be at risk of NEC. That is from the oral mucosa and the skin and the stool samples, and it is analyzed every day. This is called as growing back analysis, in which there is any change in the pattern of the microbiota. That is, it can be either the proteobacteria or the Clostridium. So the proteobacteria includes a group of organisms which regularly cause NEC, that is the gram-negative organisms like E. coli, Klebsiella, Snitobacter. So is there any search in the proteobacteria which leads to the incidence of NEC in such neonates, that is very low birth weight neonates? There are different studies which they have done this, and you can like there are so many articles, recent articles which based these growing bag analysis in identification of NEC. One of them is published in the BMC of Bioinformatics in the year of 2022. So now let us see in detail about this Hero monitor. What is Hero monitor? The Hero monitor is the heart rate observation score. The monitor will look like this, in which there should be a variability in the heart rate. Usually the heart rate of the baby increases during the inspiration and it decreases during the expiration. So this variability is normal. Lack of variability is abnormal. This monitor will detect the subtle irregularities in the heart rate variability. So we can earlier I have shown you our multipara monitor. We can plot the heart rate every hourly. Blood pressure, continuous blood pressure monitoring also can be done, and these can be plotted on our paper every hourly or every half an hourly, as frequently as we instruct our nurses to do. And we can also see the trend of the respiratory rate, heart rate in the monitor. But these subtle changes in the absence of heart rate variability, these all cannot be done in the regular multipara monitors. So that is where this Hero monitor helps in early detection. So there have been many number of studies where the lack of variability in the heart rate predicts the earlier onset of neonatal sepsis. So this lack of variability occurs hours and days prior to the patient's deterioration, thereby providing an early warning to the patient in distress, including sepsis, NEC, IVH, various other factors where the baby will go into clinical deterioration. So there, in addition to the decrease in the heart rate variability, there will also be transient heart rate decelerations, which can be plotted on the graph over a period of time. And these results are given in a numerical form. The value of the Hero score is between 0 to 7, and any value which shows more than 2 is significant. So in this way, the artificial intelligence can help us in diagnosing the baby who might go into other signs of clinical deterioration in the earlier phase itself. So this monitoring with this Hero score has been shown to decrease the mortality and morbidity in VLBWs from 10.2% to 8.1%, and also similar outcomes in the extremely low birth weight babies. These are the different studies which have been done in the various parameters that I have discussed above. So the other one is the Comet score. What is Comet score? Continuous monitoring of event trajectories. That is, it will include the study of various ECG waveforms, vital signs, lab data, and the patient events for up to 12 hours. And it also gives us a comparison of the between the different parameters such as heart rate versus respiratory rate, heart rate versus SpO2, and respiratory rate versus SpO2. That can also help in predicting the need for intubation in any baby. That is a sign of clinical deterioration, and it can also predict the uh, uh, potential of the baby in going into failure of extubation. This way, you can also decide based on the clinical condition of the baby, and this Comet score also helps us in understanding the condition of the baby even better than what we can do with the traditional monitoring. So now let us see the recap of the cases which we have discussed earlier. In the case 1, the baby, 34-weeker baby, antibiotic was started in view of the early onset sepsis risk factors in the mother like maternal fever and also PPROM. So subsequently, the sepsis screen was done, which turned out to be negative. The blood culture also turned out to be negative in 36 to 48 hours. Baby also clinically improved, and leading to the weaning of the respiratory support, initiation of oral feeds, and antibiotics were stopped. Because the culture was negative, so we started the antibiotic empirically based on only the risk factors of early onset sepsis. So this was not even a clinical sepsis in that baby. Not even clinical sepsis, not even probable sepsis. It was only suspect sepsis. So in the case 2, the baby who deteriorated on the 25-weeker who deteriorated on day 6 of life. So the baby had started showing some clinical signs of sepsis in the form of reopening of PDA, feeding intolerance, abdominal distension. So then empirical antibiotics were started. So here also we don't know whether this antibiotic will actually work for the bacteria which is causing infection in that baby. So then we have to wait for the blood culture report. So in the meanwhile, the baby started having worsening thrombocytopenia. And the blood culture report also early report, back take. So this is where those, instead of the conventional blood cultures, the newer blood culture methods help. So we will know by 24 hours itself whether an organism is growing, and the sensitivity will be known at least by 36 hours. So if not, we can opt for those faster methods like PCR based methods and PCID methods. So we found out the organism was carbapenem resistant Acinetobacter. In this case, if the antibiotic was upgraded to meropenem in this baby, that is not obviously going to work. And the baby will not start showing the signs of clinical improvement, definite signs of improvement. So then, since it was a blood culture positive infection, the CSF analysis was done, which was negative. So then the sensitive antibiotic was changed in consultation with the infectious disease specialist or based on the sensitivity pattern and consulting with the microbiologist. The sensitive antibiotic was changed, and because this was a culture positive sepsis, the antibiotic was given for 2 weeks, and then we could save this baby. Baby also started showing the clinical improvement. In the third case, where the signs of sepsis were very subtle because the baby was already on full feeds and baby was 4 weeks old, baby is on minimal respiratory support, baby is in KMC. So this baby was very unlikely, based on the risk factors which we have discussed in the case 2, very unlikely to have the such florid sepsis. So this initial part was missed. So then by the time the baby was started on the antibiotic, the baby went into florid sepsis, and the baby could not be saved. So in this scenario, the early diagnosis parameters, all the biomarkers, so everything the microbiome testing, molecular testing methods, and artificial intelligence related monitoring methods, and the various parameters where we do the everyday bedside in total examination of the baby, so helps in saving such babies and also helps in reducing the mortality in such babies. So this is about today's talk about early identification of neonatal sepsis, which helps in decreasing the mortality in the babies, and the role of various biomarkers. So we should have a brief idea about the different biomarkers, and we should also know the blood culture is a gold standard, and we should collect sufficient quantity of the blood culture, and how there is a technique to collect the blood culture, from where the sample should be drawn, how it should be done in an aseptic precaution and sent to the lab, and then finding out the blood culture reports, And also how the sepsis screen, like a combination of two factors, will help us in ruling out the sepsis, and how the combined approach is the best. Calculate the sepsis risk based on the maternal and perinatal risk factors, baby's clinical condition, the vital parameters and perfusion index as we discussed, the lab parameters like the sepsis screen parameters as such, and also the other ones like procalcitonin, IL-6, and various other parameters in coordination with the X-rays and echo. They help in echo helps us in looking for the volume of the IVC, need for volume, need for inotrope support. So what's actually happening inside the baby, and which inotrope is going to work for the baby, whether the volume will work or not, is the PDA there or not. So all these, so many factors. The focus like is like now the newer emerging thing in everyday rounds and decision making of neonatal babies. So we know that the combined approach is best for the babies, and now as more and more advances in artificial intelligence are happening, AI based tools also help in improving the outcomes of these neonates, which are at very high risk of sepsis, as I have already discussed. And they are the ones who will have the, like if we treat them properly, they are the ones who will having a long life and decrease in the mortality, so once properly treated. So that's why artificial intelligence is very helpful in neonatology, and we should always look for newer and newer methods which help in our everyday treatment decisions.